But again, welcome, Karen. I appreciate your time and your effort here today. It's great to have you with us. I want to start right off and let you give our students and our other audiences an opportunity to just hear from you about who you are, what you do, how you got into the field, where you work.
Okay. Happy to do that. As I said, I am a social worker. I work at OSF Healthcare, Heart of Mary Medical Center in Urbana, Illinois. I came on here in 2013. The focus by the CFO of the hospital was to start a department that would provide outreach. First intent was that we would contact those people who are in the emergency room on a regular basis to find out how we could help them get connected with primary care physicians. What we discovered was that a great many of them could not afford insurance. Many of them were street people. And at the same time, at that point, it was when the Affordable Care Act was coming into itself. And through that Affordable Care Act, we were able to get a great many of those individuals that were being seen in the emergency room for standard care connected with insurance and thereby connected with primary care physicians, which helped to cut back on the number of revisits by people to the emergency room for non-emergent care.
Right. And that, please go ahead.
We have evolved since then to doing outreach to people in need of just about everything, financial care, getting connected with health insurance, getting connected with food services, anything that impedes their being able to function on a day-to-day basis.
Very good. And Karen, I'd like to ask, if I can, again, I want to delve into this just a little bit, unpack it for the benefit of our students and everyone else listening. Again, emergency rooms are there, and at least in the state of Illinois, and I'm assuming this is the same in many places. If you come in with a complaint or a symptom, they are obliged to provide you at least some degree of care or triage to get you taken care of. And the issue that you're having is the fact that people would use that as their first stop, their first course of action, if they were, medically fragile, having some kind of difficulty, whatever it might be, whatever their symptomology was, they would show up here first. Now, as I understand it, the problem with that is that's a really expensive visit, because it takes all the resources of the emergency room and puts it into someone who basically may just have, acid reflux or something that, is difficult and a problem, but not necessarily something that would be emergency. Is that pretty well kind of where you were at with this and the reason for some of this intervention?
Absolutely. We cannot turn a patient away that comes to the emergency room for any reason. And just the basic test, blood tests, x-rays, whatever they're presenting with. So if somebody comes in and says, my stomach hurts, no specific issue, but so then they're going to do possibly an MRI to see if there's something going on intestinally, or maybe it's an appendix problem. They're going to run all those tests, and they can run anywhere from $5,000 to $10,000
of testing per complaint per visit.
Correct.
Okay. Yeah, I'm not real good with math, but it didn't take me long to add those zeros up. That could be very expensive, couldn't it?
It does. It's very expensive, and because they don't have insurance, then it is done on a charitable basis.
Mm-hmm.
And so it comes out of the pockets, and makes it harder to operate a business even though we're nonprofit, we have to break even,
You sure do.
to pay salaries. So getting people connected with the services they need helps them and it helps us.
Right.
A great many times, especially in the wintertime, the homeless population would be in the emergency room just to get warmed up.
Yeah. Yeah. I've got a headache. Can I stay here for the afternoon? Yeah. Yeah. A lot of people don't realize that, those open doors, and again, the care that's provided there and the open door policy, or just the fact that the doors are open, can be very meaningful to people who are looking to abate things. Again, as we're recording this, you and I are both experiencing quite a bit of snowfall today. It's cold outside, the wind's blowing. And I know if I were out, I'd be looking for a warm place that I might be able to grab a cup of coffee. Karen, another thing I want to ask about here, and you mentioned it, and I want to kind of follow up with you about it, is that your efforts and what you originally got recruited for, and kind of your mission there at the beginning was you wanted to get people from coming in the emergency room and get them where they had what's known as a primary care physician. And could you explain what primary care physician would do or could do, and kind of what the idea of a medical home is, and why that would be important for this section of the population?
Okay. To begin with, when you go to an emergency room, it's an emergent situation and they treat just what you present with. When you go establish yourself with a primary care physician, they begin a medical history on you. They know, and the longer you're with them, they become to know what your symptoms are, what your needs are, and what they also have a ready record of what your medications are. So that they're not prescribing something that will interact or against another medication.
Yeah.
So you build a history and you also build a rapport with those physicians and a trust that goes both ways. That you're going to, keep your appointments and you're going to follow what the doctor's instructions are, and that the doctor will give you the time you need to voice your issues and your concerns so that you can get answers to the questions that you have.
Yeah, I think it's so important. And again, we never consider that aspect of that medical home, that GP, what they can do for you, and that idea of building that history in terms of not only treating the acute symptomology that you have, my stomach hurts, but also being able to monitor you from a long-term perspective to say, well, are you taking your, anti-acid medication? Are you on this? Do you have a prescription for that? Are you, how's that working for you? Do we need to change it? Do we need to modify it? That's not the kind of service that the emergency room is designed to give, nor is that its mission. It's designed to do what's right in front of it when it's presented.
Absolutely.
Yeah,
And
that could be. Yeah, I can see where that would be really, really problematic in terms of trying to ensure the long-term health care. We'll put those two words together, health care, for an individual.
yeah. And I think it's important for the patient too, to know that they are able to get in and that the doctor will have the time to spend with them that they don't get in the emergency room. Because let's face it, in the emergency room, you've got extreme cases coming in and it takes the doctor away from getting to you on a timely basis. You may be there for 4 hours because they've got somebody in with a heart attack or who is unable, can't breathe on their own, or whatever the emergent thing is. Those people are going to get taken care of faster than somebody that comes in with a headache.
Yeah, yeah. Well, and I think we can understand that rightfully so, why that would be the case. I also want to get you to talk to me a little bit here about this idea of you kind of generalized in some ways, the targeted population that you're wanting to work with and deal with. But I wonder if you could be a little more explicit about that. What do you see in terms of the individuals that would be the ones that are most frequently coming or would have been coming to the ER? What is their demographic? Who are they? What do they look like?
Well, up here, we call our homeless population people without an address. And that's a great many of them. And it's people who have substance abuse issues, have mental issues that make it impossible for them to work,
Mm.
and are basically on the streets for the most part. And these individuals, and we've been very proactive in the last couple of years where we've opened up a full-time shelters for both men and women so that they have a place to go at least at night to get where they are off the streets and able to sleep, which we hope, keeps them out of the emergency room for the most part.
Right.
We have gotten a lot of the people that come to me that are not on the streets are those who are very low income, living on SSI or SSDI, which amounts to generally less than $1,000 a month.
Mm.
And when you're trying to pay your insurance, not insurance, when you're trying to pay your rent and your utilities and buy food on $700, $760 a month, it doesn't go very far.
No.
And so we help those individuals get connected with programs that assist with paying utilities, get vouchers to help with their housing, so that they're paying 1/3 or so of their income for rent. We have food pantries, a lot of food pantries in the area, but we also have one organization that is involved with several of the churches in the area that take names and their people's information and deliver food right to the home.
Mm.
And then we have organization right here in the hospital called Faith in Action that works basically with the senior population and makes sure that their needs are met.
Mm.
So that we work together to make sure that all those individuals who are either shut in or just basically living from, the beginning of the month, they get a check and it lasts for 2 weeks and then it's gone.
Yeah.
So making sure that they get the services and that they need so that they have food and they have the shelter and they have the heat and air conditioning all year long.
Sister, it's a great, it's something that I think we don't pay enough attention to. And, at first blush, it doesn't seem like it relates. But when you talk about, trying to keep people out of the emergency room, that's our mission, our goal, not because we don't want to care for them, but we want to care for them in a different way. That we're talking about the idea of mental health. We're talking about the idea of rent subsidies. We're talking about the idea of being able to provision transportation and at least some vestige of a regular meal. When we talk about healthcare, it's not just the aches and pains and the diagnoses work, it's the whole person that presents at the door of the emergency room. And it takes all of those resources at various levels and times to actually make a dent and make an impact with their lives to in fact keep them out of the emergency room. I think that's fascinating that you bring that up in that way.
People don't realize health is a homeopathic thing.
Mm-hmm.
It's not one thing that contributes, it's everything that comes together. Food, economy, your health, your mental status, having somebody to talk to. One of the things that Faith in Action does for the seniors is just to call them once or twice a month to let them know they're not alone. So it's actually coming together with the people who are in need to let them know that we're here for you. Let us know what you need. And then finding ways to provide for those needs in the most creative way so that they're not alone. They have somebody to talk to them. They have somebody to hear them and follow through for them.
Karen, I know you're not necessarily a medical clinician, but you are sort of place-based within the hospital there. And I'm sure you get an idea of what some of the let's just say some of the chronic issues and conditions that this demographic faces. I wonder if you could just speak to that a little bit. When, let's say that somebody is intransient, they don't have an address, they're not feeling well, they walk in the door. Uh, what normally, in terms of not necessarily acute issues, but these chronic conditions that we see, what is more prevalent, or what do you see prevalent in these populations per se?
Um, Most prevalent thing I think is mental illness. Um, when you don't know from day to day where your next meal is going to come from, or if you're going to have a place to lay your head, or, my shoes are wearing out. How am I going to get a new pair of shoes? Um, just small things that we all take for granted that play into breaking you down and just making you feel like nobody cares what I'm doing today, or if I'm going to wake up tomorrow morning. We need to provide the outreach to them that says, we are here for you. We're willing to listen. What can we do?
Mm.
And continue doing that. It takes a long time when somebody's been on the street to break through barriers that they put around themselves to keep themselves safe. When you're on the street, you don't know who you can trust. And even if you develop relationships with people, I've talked with guys who have thought that these people were their friends, and when they cash their checks and they keep their money in their shoe, or they keep their money stashed somewhere, they'll wake up the next morning and their backpack or their shoes will be empty. The money's gone. And so you don't know who you can trust. And until you break that shell and let them know, we're here for you, we're not going to take from you, we're trying to give to you and help you to find the resources. We've started a program at the shelter here that when a homeless person is in a shelter for 10 days, we can get them signed up on a list to get a voucher for housing. And that will help to get them into stable housing and into the programs that will allow them to get, like I said earlier, help with their utilities and a way to get food on a regular basis, whether it's delivered to them, or if you go to the Daily Bread and pick up a meal there once a day, and they give you an added meal to take with you so that you have something at night.
Yeah.
It's building that rapport and relationship that allows them to relax enough to open up to you so that you can be of greater service to them.
Mm. That's a fantastic point of view, Karen, and the fact that we don't take into account how highly stressed the people living in these conditions are, and that what impact that stress has not only mentally but also physically as well. Uh, I'm curious, Karen, about how, from your point of view, again, how folks that are in this situation. I have two questions basically. Let me start with the first one. How many times? Let's say that, and again, I'm confident your project and your program has been successful, but tell me about the frequent flyers. I mean, the people that you just can't seem to keep them out. Are they coming because of legitimate issues that they don't know how to manage or control? And again, I'm just thinking out loud here. I don't want to presuppose that I know what you're going to say, but I'm thinking about somebody who has chronic diabetes or something like that. That I may not know what that is, know how to control that, and I'm lucky if I get anything to eat, let alone on a daily basis the right thing to eat. And I don't know how to take medication, or let alone inject myself with something helpful. How does your program work to try to keep those people? Again, I'm assuming that's through this idea of the medical home and the service providers, the general practitioners. How does that work to keep those kinds of issues that this population may see under in check?
Well, there's a couple things that play into that. I think the most prominent is that, again, they're on a fixed income, so can they even afford to buy? Or all they have to pay is their copay. But sometimes when you're dealing with $760 a month and you've got a $5 or $10 copay that comes late in the month, you haven't got that $5 or $10 either. So you can't even afford to get your medications.
Right.
So we do help in that outreach so that people are staying conforming or with the orders that their doctors give them. They're not neglecting taking their medications. We have nurses that do contact people, and some of my staff, we contact people after they've been in the emergency room just to find out what brought you in, how was your care, and what else can we do for you? Well, I can't afford my blood pressure medication, or I can't afford my diabetic supplies this month. You know, and some of the pharmaceutical companies have programs that help people who are low income or cannot afford their medications to get those medications either for free or really reduced amounts of money. And we can get them connected with those as well. When they come in at their first time, just becoming acquainted or finding out that they're diabetic, we take the time a nurse will talk with them and show them how to do the test and how to give themselves the injection. Yeah. They use oranges, which is really interesting, to show them how to stick themselves.
Oh, to practice on? Yeah.
To practice on, so they learn how to stick themselves. So they do as much as they can to help the people become as literate about their conditions as they possibly can.
Yeah, that idea about health literacy is a huge subject. And we may take another interview at some other point in time about that, and have you guide us in understanding that a little bit more, because again, I think that was actually sort of the predecessor of my next question, and that is, given all the constraints that this demographic and this population has that you're working with, from your point of view, what does compliance rates look like? And by that, what we're talking about here is the idea of, well, if I'm giving a prescription, can I get it filled? If I get it filled, do I take it as prescribed? And do I monitor that and make sure I'm following the doctor's suggestions and their orders? What do you see, Karen, from your point of view, as the ability, first of all, the ability to be compliant and the willingness to be compliant in working with the doctor and the doctor's instructions?
Diabetics are generally, once they get on their regimen, they stick with it. It's people with mental illness or addictions that are less likely to be compliant, because the drugs themselves have such an effect on them that, I'm sleepy, or I can't function. I can't think because of that medication, and I'm feeling better, so I'm going to go off it. Yeah. It's a matter of educating them that, if you have a broken arm and they put a cast on it, and it's cumbersome to you, so you got to get rid of the cast, and your arm's not going to heal properly.
Right.
Well, that's the same with your mind. If you're not taking the medications as prescribed, then your mind is going to relapse and you're going to be back to where you were. And you see that so many of the people are diagnosed with bipolar. And I always thought that bipolar was a extreme high or extreme low. And having been working here and talking with people, you learn that bipolar has many different asset or facets, where it's not necessarily an extreme high or an extreme low, but anything in between those two where you're not functioning, your mind doesn't support what you want to do on a daily basis. So, and people that I've talked to are on those medications, I get to feeling so much better, but, as far as being able to be myself, but I can't think. And I find holding a job sometimes to be difficult because I can't focus on something. So I stopped taking the medication. So then you relapse and you lose the job.
Yeah.
And you're right back where you started. So
That's a fascinating, and you're right, that circular thinking process. I have a nephew that actually is schizophrenic, and he is a wonderful, charming, really intelligent young man as long as he's on his medication. And as a matter of fact, he's so wonderful, so charming, and so intelligent that he talks himself right into thinking he's cured because his medication is so effective. And for him particularly, he has, I would say, very few side effects, but it works so well for him. It's like, guess what? I'm cured, man. I'm good. I'm good. Don't need that anymore. Don't need to have the sleepiness or the irritability or something else that comes with that medication that I don't like. I'm cured. I'm off of it. And then 2 weeks later, he's having an episode and
right.
that kind of, so it's very circular. And again, I can only imagine how difficult that would be if for somebody itinerant, no home, no address, living on the street, what have you. Just incredible depth of needs there. Karen, tell me a little bit about the overall impacts, I guess I'd say, of this broad-based programming that you're working in. I'm interested in you telling me about, again, you already mentioned about a half a dozen different aspects of not only things the hospital there is doing, but other community efforts that are taking place. If we were to say to ourselves, well, if we could wave a magic wand and say, we're going to solve this problem, as we define it, whatever this problem is, homelessness, medical indigence, however we want to define it, what do you say would be the number one or number two thing that we really ought to be doing around that cause that would be more helpful? Obviously, you folks have done a great deal of work in that area and trying to meet those needs. But if you could be queen for a day and wave your wand, what would you do? What would be the one thing you'd do that would make you, from your point of view, make the most difference?
Find ways for there to be more affordable housing built to accommodate those who are on fixed incomes, whether they be seniors or people who have mental illness or addictions, or just can't, for one reason or another, work. It's when you are told, when you go looking for an apartment, and I mean the cheapest apartment, we have people that we get in to apply for a $500 a month apartment.
Mm-hmm.
And they tell you you have to make 3 times the income. So if your apartment is $500, you've got to make $1,500 a month to be able to afford to even apply for that place.
Right.
Okay, so you're on a fixed income of $760 a month. What's that do for the person who is on a fixed income and they're not going to get that housing, even though they could probably afford $500 a month and $100 in utility bills and still have a little left over to buy groceries. So, it's a big need for affordable housing, whether it's government subsidized or somebody that builds a place and doesn't want to make a huge profit on it.
Right.
And to accept those people that are applying where they are. And yes, there has to be conditions. I understand that. You have to pay your rent on time and you have to pay to keep your utilities up. But give them the opportunity to at least try most of the people I've worked with that get into a place are so thrilled with being there that they do what they have to do just to be able to live somewhere.
Yeah. Sounds like you're going to be busy here in a minute.
Yeah, phone's ringing.
I know, I know. Listen, I'll let you go here in just a second. One last question I would ask of you here, if I could. Uh, the the needs that you've expressed from the client standpoint about what they need, again, mental health, housing, all of these sort of wraparound services or contingent services that need to be provisioned for them in order to keep them healthy, keep them, again, out of the emergency room. From a standpoint of your agency and the work that your nonprofit and the work the hospital does there and what have you, what is its biggest need in terms of trying to work with this population in general? What would you say its needs would be?
The hospitals,
Yeah.
um, cooperation, I think, with insurance companies that don't tie their hands on what they can do with those who come in with a limited amount of insurance. Help us to help them,
Yeah.
to get them the medications that they need and to provide for them as we would someone coming in with the best insurance in the world, be able to provide the outreach regardless of what their income and financial status is.
I could certainly see that as being something very needful. A lot of folks that don't have to deal with it, don't have medical conditions to speak of, don't realize how influential insurance companies are in terms of practicum of care and what happens when you walk in the door of a practicing physician or a healthcare organization. How much of that is actually controlled and mandated by external third parties that
Mhm.
basically say what they'll pay for and what they won't pay for, regardless of what your need is. You know, uh,
Right.
yeah. Well, listen, Kara, I will let you go. Thank you so much for your time today. Listen, bless you and all the folks there for the work and the missions that you do. Champaign-Urbana is a better place because you and your organization is there. And I know there's always more need than we have resources to deal with. But I appreciate you giving us this insight, talking with us today, and helping us to understand this idea of healthcare and how it impacts the whole person overall. Thank you so very, very much.
Ron, it's been my pleasure, and I hope that your students get something out of this talk, and I'll be happy to answer any other questions when we do the live talks in a couple months later this month.
Yes, I'm looking forward to that too. Thank you
Okay.
again, Karen, so much. All
Okay.
right. I'll let you
Got it.
go. Have a great day. We'll see you.
Okay.
Bye-bye.
Bye.